you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pettis.
That is the Pacific Ocean. And this is our classroom. So just saying.
Just saying.
I only seem like a nice lady.
Yes, you still are a nice lady. And I will be there next October.
October.
Yes, done and done.
Yeah. I have to talk to Joseph and see how big the classes can be, but I actually don't care how big they are. It's like, there's actually, besides the visual beauty, there's no way to describe how it feels. Let's put it this way. Kevin falls asleep by 9 o'clock, maybe 10. Wendy and Danielle are both, you know how on it they always are?
Yeah.
They're mellow.
Yes.
Yeah.
Isn't that a gift to just be? And that's really funny that we're talking about this, because some of the things that have been pushed down my list, I was like, no, we are talking about it today. And part of that, slow down, get in your body, be present, can be very difficult for people. And
oh yeah,
when I think about that one slide in the core that always stood out to me was, if you've ever tried to apply a Band-Aid to a screaming 3-year-old, you understand this concept. And I feel like that kind of chaotic energy is so common nowadays.
Especially in the US. It is not
universal. Yeah.
Yeah.
And it doesn't matter if you're an athlete or somebody in their 80s. I come across this all the time. And I think when we talk about with treatment and FSM and where to start, getting somebody to just quiet the noise and get into their body and take a couple deep breaths, like, you're never going to get the full story, B, see the movement, C, get the true pain scale until that level that's up here comes down over there. So amazing that just being in a place of the world can have that effect.
There's almost no way to describe it. But speaking of that, I have to tell you a story about what happened.
Please.
Last night. One of the students here, we have people here from Ireland, Mexico, Switzerland, the US, a couple from Costa Rica. Anyway, there was one of the practitioners here who her pain level was an 8, and watching her walk and watching what hurt looked like an SI joint. And we have 2 manual trained physical therapists, both of whom have 40 years worth of experience.
Right.
And so last night, I was going to ask them if they'd work on her, and they already had 2 machines out, and she was getting on the table, and that was happening.
Yeah.
And so they're heading for the right lower quadrant of her abdomen.
Mm-hmm.
That's just, they have hands that know where to go.
Yeah.
And so right lower quadrant of the abdomen, they start feeling around for scar tissue, And she said, oh, I had an appendectomy. I had my appendicitis in Switzerland when I was 19. And so she's in the ambulance on the way to the hospital. And the hospital is 2 hours away from where they picked her up. So an hour into the trip, and we're talking code 3, let's get to the hospital. An hour into the trip, they pull over at this cafe and stop, because it's like an airline pilot. You are only allowed to work so many hours until you take a break. So they leave her in the back of the ambulance with her pain level at an 8 in the lower right quadrant where your appendix is. And they go in and get coffee. They don't give her pain meds. Like, she's just there. And one of the physical therapists, and they've both been doing FSM for years, one of the physical therapists asked, you must have been really afraid. And she said, I was terrified. At which point, this physical therapist who's working on the scar tissue in the abdomen runs 970 and 27. Terror. Now, number one, who but an FSM manual therapist would think of even asking that question? That's the first thing.
Yeah.
Then they left her in the ambulance, went into the cafe, and the PT asked her, did you feel abandoned? She said, that's exactly it. They abandoned me in this ambulance. So the therapist runs 970, and everybody can look at their laminate now, 970 and 22. And it's like the whole pelvic floor and abdominal cavity just disappeared, just turned to pudding. And then they got to work on the physical part.
Right.
And these two are something else. With any luck, I'll be able to twist some arms and beg and plead, and they might show up to be assistants during your FSM rehab course.
Sure.
And that, thank you for agreeing, but I've never met anybody like these two, except maybe you. But you add, how long have you been doing manual therapy?
26 years.
26 years. Add another 20 years
Amazing.
of mileage to what you have.
Right. Amazing
And
collaboration.
they could be helpful, or at least interesting.
For sure. So this story that you're explaining is very similar to part of the sports course, which will turn into rehab course. And I'm very honest with the fact that after it took me 3 cores to even stop rolling my eyes at the emotional frequencies. I thought they were just weird. And it just, give me the scar tissue, give me inflammation, give me the locks and cogs data, give me all of that. But the emotional stuff just I didn't buy it. I'll be honest with it, until I was working with that athlete who had such great dramatic results right off the bat. But at treatment 3, we had a plateau and a stumbling block, and I could not figure out how to get more glute flexion or hip flexion because his glute was so tight from a traumatic injury during a game.
I remember.
Yeah. And the stories he started telling me as he was getting floaty on the table, and he'd say things like, do you hear the team is winning? And he's so angry about it. I'm like, yeah, it's great that they're winning. No, they're winning without me. And there was that click that I heard: abandonment, fear, right? It's great that he's a professional athlete, but when he's injured, there's 10 more waiting to get called up and to replace you. That is the nature of being a professional athlete. And yes, you get paid a lot of money, but that is to deal with the fact that they could be done. They could
You're expendable.
Or expendable, right? They could have a career limiting injury or just not be performing. And it's like, next. So that was what I knew. I had the physical stuff done. I knew there was still a ways to go, and I could not figure out what other frequency physically would help me until I heard the fear, the abandonment, even loneliness, right? Everybody's gone.
Yeah.
And
Yeah.
he's left to try to deal with this. His family's not there. There's all these things, and it shouldn't have worked, and it did. I could measure range, and that was the thing. I'm like, how do you measure range of motion with emotions? Well, you do. I could measure that I was gaining more hip flexion while running the emotional frequencies. And when it all turns to pudding, then you're able to go deeper, and then you're able to figure out, once all that guarding is done, once that whole layer of whatever softens, and then you're able to do a little bit more, whatever you need to. But that was the absolute game changer. It changed my practice forever. And anything else, once you see it, you can't unsee it, or you can't unhear it. You can't unhear the stories. And then that guides you as a clinician to start asking better questions. How did that feel for you? Explain to me what you were feeling during that. Tell me what you're going to do when blah, blah, blah. So the story, you get better at asking questions to get better stories.
Yeah. And the other thing that has changed in the course, so there are two manual therapists, one especially, he took the core back in 2006. And that was only because Kathleen Casbin pitched a fit and threatened him. It's, you have to take this. She's coming to Asheville. Actually, it was 2002. And so he hasn't taken a course since.
Wow.
And I look back at how much it's changed, how much the focus has changed. And I look at what we're doing in the core now, where right off the bat, when we do the supine cervical and the neck and shoulder, where right off the bat, partly because of you, partly because we both thought of it at the same time, afraid to move it. 40 and 89 was working on this lady's shoulder. And when we got her into external rotation, I said, where does that hurt? Because she just stopped. And she said, in the back. And I put my hand where the infraspinatus tendon should be. And there was an innie instead of an outie. So the thing has got a good solid partial thickness tear. And so we took a second machine and set it up to start working on torn and broken in that tendon. And then finished getting her arm up passively. Now, these two manual therapists want me to do it actively, and it's, oh no, not yet. Watch. You have to do 40 and 89 first. And everybody looks at me and goes, what? Her brain afraid to move it. When you explain the pathway, the sensory cortex will say, I want to do this, but it has to go through the fear center. It has to go through the hippocampus that remembers she hasn't been able to move her shoulder in 8 years. And her brain remembers, her midbrain remembers that's going to hurt. So you have to, as you would say, give it a binky and a blanket, tell it to calm down. It's going to be fine. And then we did the cerebellum, and she did active movement, and you could see that it got more coordinated every time she moved it. And then I said, now watch. And we did 81 in the sensory cortex. and the quality of the movement changed.
Sure.
When the sensory cortex went, oh, that's where they are now? Oh, okay. And then it wasn't coordinated, but it was willful, if that's a word.
Willful, I like that.
She could
Yes.
intend movement. And we went back to the cerebellum because the midbrain was in the corner napping. And then we went back to 81 and 84, increased secretions. And then you could see the difference in the quality of movement once the sensory cortex knew where the muscles were,
Right.
and it sends a message down to the cerebellum.
Yeah.
We start that the second day now, instead of waiting 3 days, 4 days.
Yeah.
It's so different.
The second you can start integrating these safe movement patterns, the faster everything is going to click into place. And it's funny because it's a bit of hypocrisy because we say there's no recipe, but this is an actual, like what I call the reboot or wipe and load or whatever, that reboot process absolutely has to be followed in steps, because I've been a manual therapist for 26 years, but I've been a trainer for 30 years. And movement is what, and safe movement and strength training and all proprioception, all those little corrective exercise pieces that help hold what you do as a manual therapist in place, they're never going to stick if that midbrain is on hypervigilance and has a story that this is not going to end well. We cannot do this. It's just going to happen. It might look normal, quote unquote, in the clinic at that time, but it's never going to hold. I could say that with absolute confidence and certainty. I have just seen it too much. And it's not that patient doesn't want to move. This is an indoctrined story that you don't, what do you say?
You don't get to vote.
Yeah, you don't get to vote. Yeah.
You don't get to vote. And it's interesting that athletes, especially, the cortex gets to outvote, overwhelm, use colorful language about we are going to do this anyway. And it will force it until it can't. And then the cerebellum says, I really don't care what you want. I'm done. It's not safe because the midbrain is yelling at it and the cerebellum is feeling the pain and inhibiting needs to be inhibited. And it's really teaching the integration of the neurophysical endocrine system. It's teaching it from the beginning and integrating it.
Correct. And what that phrase is right now is called interoception.
Okay.
And that is the phrase that we're using now. Interoception is that intrinsic feeling that movement has to feel safe and good for the patterns to stick and hold. And there's just so much research right now supporting sort of this hypothesis that you and I have had for quite a while. And another thing to go back to what you were saying is there's that feeling it's not safe. And then you have an athlete or a certain type of person that is just not going to stop because of the injury. The mother of 3 kids that is going to have to get dinner on the table, whether her rotator cuff is torn or not. There's no escaping. There is no resting. There is no nothing. This person is going to keep moving until something else happens. So we have this slide, and I'm turning into you, where I've realized a slide or a picture in a slide has to be shown 7 or 8 times for people to see it one time.
Forward. Yeah.
So I have this wheel of movement, and then you have an injury, and then the motor control center decreases signals to protect the area. And then there's this bridge of after a certain amount of time, that is the new normal. And then that new normal creates another injury because of the compensation, the abnormal firing patterns, the inhibition, whatever is happening on that arc. And that's where you have to interrupt things with FSM. It's like hitting Control Alt Delete. Okay, let's go back to business now.
Yeah.
You're not injured anymore.
Yeah.
Let's move on.
Yeah. And the other thing that's become obvious to me, because I'm back on a cane, after Eduardo loosened all the adhesions in my dura, I was amazing for 3 days. I could extend my right hip. I could do all this stuff. And then my quadriceps and adductors had started hurting, burning. That's weird. And then it's progressed to the point where I can't bear weight on my right leg sometimes. So 2 manual therapists start working on me. And it comes down to lower abdominal adhesions from, she said, what happened in your abdomen? Oh, I had a ruptured ovarian cyst and 2.5 pints of blood in my abdomen when I was 19. Yeah, that would do it. She said, because you've got adhesions all over here. So she took apart my abdomen. And then roughly at the same time, you know how I tell people in the beginning now, see with your fingers? There comes a point when you can see inside. And as she begins to move my pelvis, I could see a dural adhesion on my sacrum, just medial to the right iliac thigh joint.
Okay.
So is my pelvis going to move normally as long as the dura is still adhered on the sacrum?
No chance.
No. And so we got rid of that. And then the abdominal surgeries that I've had, and I started counting them up, and the 2 of them looked at each other and went, okay, fine. And they had a towel on my low back. John put a towel around my knee, and we did 40 and 396. I did not know that my right glute was not firing. I have been telling the femoral plexus adhesion story for 20 years. And John reaches down to this rec fem that is now jammed into my hip capsule and spastic, and grabs my femoral plexus. And there was a certain amount of screaming involved. And then I taught him how to take it apart, because back when he took the class, I hadn't treated that runner in Australia, and I hadn't told him about that.
Right.
You learn so much about everything by being injured and repaired. So they took apart the nerves, and then teaching my brain to find my glute and getting the glute to contract, because as it turns out, the medius and the minimus and the gemelles, because the piriformis is also turned off, the medius, the minimus, and the gemelles are doing all the work. And they, at this point, have an opinion about, you want me to what? And it's been, I don't know, a week of this.
Right.
Who else except an FSM practitioner? And for all 35 of you that are listening, you have the perfect right to feel slightly superior to the rest of the mortal world that's doing manual therapy.
Yeah.
Because nobody thinks about it because nobody can do it, and you can.
Yeah, for sure. And the other huge like shift, I think, in a FSM practice is your motor output turns into sensory input. You are now a satellite dish waiting for information, what this body is telling you, what the tissue is telling you, what their words are telling you. And I'm so grateful for that slowdown in my practice, because without it, you're just using your hands, telling the tissue what to do. And the last time I checked, somebody who has been injured or traumatized doesn't need to be told another single thing. It needs to be listened to. Going back to that toddler analogy, that toddler that's having a temper tantrum, it needs to be told, I hear you. I understand you. You're safe. It's going to be okay. And
Yeah.
And then everything starts to just come back into their body, come off the ceiling. Now we can move forward.
But people trust when they're listened to.
Yeah.
And I think that's the first time that's ever come out of my mouth. But people trust you when you listen to them, and they don't talk to you unless you listen to them. And when your fingers see inside and your fingers listen, and your not only your ears, but all of you listens.
Yes.
And it starts in the core when they're doing the shoulder practicum, and the students are told, don't pay attention to what you feel with your fingers. You'll feel the tightness. Watch for the scrunchy face. When you get the scrunchy face, back off and give them a second to get on top of the pain. Wait, listen. And your way of saying that is they need to feel safe.
Yeah.
It's
the platform for somebody to tell you a story it's really invaluable. And whether that is somebody who wrote in their history the trauma that they have, or somebody like my law enforcement officers, my firefighters that have seen so many horrific, catastrophic accidents or experiences, and they utilize that time with me to purge the details of it. And it is that safe place to tell me about the case, tell me about the call, tell me what hurt, tell me what your body was doing in that moment. And they've all said what an important hour that is, because they can't tell their feelings maybe to the other guys on the force and in the department. Their spouses have probably heard every story and they don't want to hear another story, or maybe they can't divulge that information. So for the practitioners that are listening, if you are treating first responders, give them that platform to tell the story, because I can't tell you how helpful it is and a lot of them want to tell you the story.
Well, and the other thing is, there's an awful lot of the times when they don't talk about it. They can't talk about it because there's too much.
Yep.
But their body will tell you.
Yes.
So you just took up a second machine and you run concussion in Vegas, and you run 40 and 89. And as the endorphins hit, I think you're the one that said FSM is like truth serum.
Yeah.
As the endorphins hit, and it's like you lessen the load.
Totally. That's such
emotional intensity. As that gets less, and it's less threatening for them to talk about it, then they might let a little bit of it out.
Yeah.
And you can find it in their body.
Yeah.
And your information that fascia conducts at 400 times,
That 700 times.
700 times what the nervous system conducts.
Yeah.
So the hippocampus is saying one thing, and the fascia is using very colorful language to say, no, thank you.
Yeah.
And so as you're working on the tissue, that image of the body being a semiconductor, and that trauma is like a pebble in a pond, and 294 is stored in the fascia.
Mm-hmm.
And then you start relieving the pain, adhesions in the fascia. I suspect that actually this is the first time it ever occurred to me to hook up a second custom care, a third or a fourth custom care with just 294 and 142.
294 and 142. That is coming on my island with me when I can only take 5 frequencies with me. It is, I use 294 and 142 trauma in the fascia. I've also been using trauma in the adipose. So I feel like it works very well with the omentum. We're using it a lot with the fat pads of the knee. Before 3 and 97 can work. So I've been using 397. So sclerosis in the fat pad.
True.
Especially for people who have had ACL, like especially the ACL, MCL, meniscal repairs, those 4 major fat pads just get trashed. So I was thinking, okay, it's 397, but why isn't that working? Again, that story is, well, before things get sclerosed or scarred, what is there? There's tearing, and before there's tearing, there's trauma. That's where I've been putting it too.
And then when we're working on somebody's abdomen, before you can even get to the omentum,
Yes.
the vagus nerve is a pain nerve.
Yeah.
And talk about having memory. So before you do anything in the abdomen, the first thing you do from the neck to the pubic bone is 13 and 109. Take out the adhesions that glue this pain nerve to the fascia, the peritoneum, the adipose, everything.
Yeah.
You have to release scarring in the vagus as a pain nerve, because we all think of it as everything else it does, but it's a pain nerve in the abdomen.
Yeah.
So you release the scarring, and then the muscles will relax and let you in so you can get to the adipose. And then once you get to the omentum, there's another layer of vagus under that, embedded in the omentum and the small bowel. So you do scarring in the vagus again, and then you can start working on scarring in the small bowel. So this whole concept that we're developing in real time of communication in the body between the body and the brain and the nervous system, and how it all works together is just,
Yeah, fascinating.
if somebody had told me that I was going to be having this conversation 30 years ago when I started treating myofascial pain, it's just, yeah, amazing.
It's the fun stuff, how things evolve. Speaking of evolving, oops, we have a few questions.
Yeah.
Hello, Leaf.
Hi, Leaf.
Done. Okay. I'll let you take that top one that Tad had written about the non-diabetic wound. Oh, yes, that case. Yes, last week when you had Ben Catholi, and it sounded like that person did everything right, and we were a little bit stumped.
And it was nerve. Non-healing diabetic wound discussed last week. It looks like algal products containing whatever that is, fucoidum, do assist wound healing, possibly by improving the microvasculature and improving the glycocalyx. That actually makes sense. Sent a longer email a few minutes ago. You can guess that teaching for a week. I haven't looked at my email in a really long time.
Yeah.
And supporting the capillaries, but it's not, but it's and Ben's information is important because in order for a blood vessel to perform its function, it has to be innervated. And if you have denervation, whether it's in dermatomal or small fiber nerves, it's a thing.
And then Annie had written, she is using capillaries. By the way, his doctor said stenosis has nothing to do with his situation.
Arg. Yeah. It's, oh, yeah.
Next question. Talk about healing a rotator cuff injury. This is from pushing a car seat into the car seat to buckle, I think. Low level pain for several years, noticing now because going back to the gym and doing weights, curious to why it didn't heal. Thought we might have some ideas. This is that.
It didn't heal because they don't heal on their own because you're always using it. And if nobody ever got their fingers successfully into your armpit, the infraspinatus is always fighting with the subscap.
Yeah.
And the teres, the poor thing. And it's not going to heal on its own. They don't just heal because it's been 4 years. Then you go to the gym and you start asking it to do weights and it's saying, excuse me, you want me to what?
Right.
No.
This is sort of that example that we talked about before, where like you're not going to stop and rest it because you have this baby that needs to be like hoisted into car seats all the time. So your lat and trap and some of the other areas in that parascapular region have come up on board to get you through the day. And like what you had just said, and now all of a sudden you're trying to quote unquote isolate it. Just let's just be clear, you can never isolate one muscle. Like that's not how the body works. But you can try to specialize. Exactly. You could try to specialize exercises for certain movement patterns. And when you go to the gym and try to do external rotation or just like a lateral raise, for instance, that is when you're going to notice that pain because like you just said, you're asking them to work and you say, excuse me, I don't participate in this anymore. Maybe you didn't get the memo. I'm out.
Yeah.
So yeah, then, going back to the beginning and rehabbing it will be important. Safe to move, important. So a lot of torn and broken.
The lady that I worked on last night is now all excited. She can actually get her arm up here.
Yeah.
And last night she said, what do I do? And I said, you park yourself in a chair and you're in about 10 hours of 124 and 77 on the infraspinatus and probably one of the teres. And then you can start light weights, low reps, and try and coordinate the movement if you can find a manual therapist that knows what they're doing. Right. And that's why we have the rehab class, so we can create a group of manual therapists that know how to integrate FSM with exercise rehab that won't injure people. We had this terrifying conversation over dinner last night about PTs that hurt people, that tear rotator cuffs, and they do it because of the way insurance reimbursement works. Right. And it's not like they don't care. Some of it is that their training doesn't include how to think about that. But in a perfect world, next year in October, when we come here, what I would like to see in your class are trained physical therapists, occupational therapists, and that need to add, and maybe any manual therapist that's already doing FSM, but teaching them how to think about how to rehab a muscle using half a pound
Right.
on. So I'm at the equator. It is 20 to 6 here. And the sun comes up every morning at 5 o'clock, and it gets dark every night at 6 o'clock.
Right.
So that's why it's getting dark back there.
It's getting dark here in California too. It's getting there. Okay, so that's done with the
What can
road.
we tell a PT and OT to get them to your trainings? Have them read the resonance effect. Tell them that
Websites.
it's the most fun that they will, and the most success that they will ever have in practice.
Tell them all the fun things that you do with it and that you see. We're working on all the CEUs too. So that is going to be huge for everybody to get legit credit for this. But yeah, the two between the FSM sports website and frequencyspecific.com website, there's just a ton of information. So
Yeah.
let us do the heavy lifting for you, Lisa. Okay, Kate. Yes. So Nassim Haramein, who's a quantum physicist, says that we record trauma in our tissues just as music is recorded on a CD. And his work, Kate, I'm so glad that you brought him up because he has also been on my list to talk about. You can just Google him, and there's just podcasts and Instagram video. Like there's so many, he just has so much cool research right now about how we do restore things. And it's more than just what's that book, The Body Keeps the Score. This is taking it in a little bit of a different light.
It's not just that it keeps score, it's that it's recorded.
Correct. Yes. And so it's just phrasing it a little bit differently. And it's got a lot of great information. So thanks, Kate, for that reminder. People, you need to look them up.
And just in case anybody is wondering, Kate Adams is the reason we do 13 and 60 to release the psoas. That's my Kate.
Yeah.
Thank you very much.
Okay.
You want to do this one? Oh, Louise.
Sure. Is it, I think it's like maybe redundant for listeners to
get.
I'm just going to paraphrase this. I think what the question is saying is that we maybe just say the frequencies as opposed to just the numbers, perhaps to just
what
we're talking about. It's hard, and that's what happens when you're at the advanced, is that you get to just speak in numbers all the time and you forget. And that reminds me of, and I've told the story when you came to Calgary and we went for lunch and we were talking with frequencies, and then you had got out to take a call because it was loud in the restaurant, and the waiter came by and he's like, "Who are you guys?" And I was like, "What do you mean?" He's like, "Are you guys like scientists for NASA or something?" It's like, "You're talking in code. Do you work for like the KGB, the CIA? Who are you?" And it was just so funny. But yes, thanks for the reminder. We'll try to translate the numbers a little bit more.
Yep.
Okay.
Yeah.
Precautions about treating someone with herpes that is controlled by medication. Can you use 40 for injuries unrelated to herpes without causing an outbreak?
I don't know.
Yeah, good.
Probably. If they're generally the phrase is they have an infection. Hi, dog. If they have an infection and they're on medication, it's safe to use 40. And because I've never had the experience of having to do that, I don't know. So try it and let me know if you get away with it, because if it causes an outbreak, all you have to do is run shingles and get rid of it. So it's not. One of the things that happened here was this patient got treated 2 nights in a row for the supine cervical practicum. One of the practitioners did. She got treated, and the second time she was treated by somebody who was not a manual therapist. And that night, my pain level was about an 8 in my hip. So I wasn't paying close enough attention. And there's only 2 of us as instructors for 16 people. And I didn't watch what he was doing with his hands. And at the end of the practicum, she gets up and talks about this feeling of fullness and pain at the base of her skull and pain in the top of her neck. And so it was a good learning experience for the class. I told the practitioner to run concussion in Vegas on himself, and he did that. And with her, I just ran 18 and 162. When he was doing scarring in the dura, he got in too deep, and there's little capillaries that the vagus is attached to at that junction where she was feeling the pain. It was just bleeding. And only in the FSM world would you say it was just bleeding. So it was reassuring to being able to tell a class of some new practitioners, you're going to get yourself into trouble.
Yeah.
That's just the way it is. You can't possibly make more mistakes than I've made. So listen to what she said. I feel pressure here. And she pointed right to the spot. It was okay. So we stopped the bleeding. And then she said, it still feels, and she described a feeling that was like torn and broken in the vagus. That's all I could describe it as. It's like, it doesn't feel right. The only thing he could have injured beside the blood vessel was the dura itself. So he ran torn and broken and trauma in the dura, and then got down to C2-3 and had to run bleeding again, and trauma in the periosteum. And then was pouring rain, and I take meds that last me all day. She has a vestibular injury that's better because she has prism glasses. So her BIVSS score is like 23, 24. So she didn't think it was a big deal. But the air pressure dropped, a thunderstorm came through, and her head was all foggy and fuzzy. I went to my purse, I grabbed 2 meclizine, said, here, chew these, take a nap. And in 60 minutes, she was up walking around, and we ran acute facets. And so you put all of it together because we have tools and awareness that let us do that.
Right. Yeah, exactly. Yeah. All right. Keep going with the questions. There's a patient, history of cancer, radiation, particularly in the chest, who took Fosamax infusions 3 times, shifted from osteoporosis to osteopenia. Yay. But her bones of the spine feel so hard, which is leading to a lot of stiffness into nerve pain. They're asking about 91 or maybe mineral deposits.
No, it's 54 and 10. You have to take the radiation out.
Yeah.
So when the patient had radiation in the chest, you have to think of radiation going all the way through.
Right.
They say, oh, we target it. You can't.
No, it's like isolating, like it's just going to go everywhere. Blah.
It just goes straight through.
Yeah.
So it hit the vasculature in the spinal cord. It hit the dura.
Yeah.
It hit the spine.
Yeah.
It hit the connective tissue in the spine. It hit the joint capsules. Did I mention it hit the dura? And
Yes.
capillaries in the spinal cord?
Yeah.
And the spine feels so hard because you have to take out the radiation, take out the inflammation, take out the scar tissue and move it, but think all the way through.
Right.
The pleura, the lung, go from where the radiation went all the way back through, and it forms a V. So it catches everything.
Right.
Intercostal nerves, the periosteum in the spine. It is hard, but it's hard because it's been radiated.
Right. And I think that's like the biggest shift. So that person who took your course in 2002 or whatever it was, where it was a list of frequencies, there was a pathology, there was a tissue, you had to match the two together. Yes, you were getting some results thinking that way. But when you start thinking of, okay, why is it scarred? Why did it bleed? Why is it hard? If you start thinking about why, and then even with that B channel, okay, I think I'm on the muscle, but what is near it? Is there a vessel? Is there a nerve? What's the fascial formation look like? By the way, if those of you who need visuals for fascia, like we use netters, Carla Stecco has some amazing pictures on the internet.
Oh my God.
Amazing, which I have spliced into and given her all the credit in the sports course, especially when we do the shoulder. There's pictures of the muscle, but then I've shown pictures of Carla Stecco's work with fascia and saying when you can see how enmeshed everything can be, how messy it looks in real time. It makes a bit of a mockery of Netter's clean little images. And yes, like both are important, but to your point, thinking about why is it hard? What's the story behind the hardness? That can get you better. That can get you further faster.
And 91 is so not the problem. It's that the periosteum has been radiated, which changes its genetics, which makes it chronically inflamed. And at some point, you may get to hardening in the fascia, but depending on the age of the patient and how long ago the radiation was, and we really can't talk about Fosamax infusions. We just don't want to have that conversation.
Yeah.
You may need 217 for calcium oxalate. It's a harder kind because Fosamax makes tissue brittle. It makes the bones look better on x-rays.
Yeah.
But it doesn't reduce the incidence of fractures.
The person that had the question said regarding the one who was radiated said she's in her late 70s. It was a long time ago. Doesn't matter.
Yeah, no, the answer's still the same. Nobody's ever taken out the radiation. Nobody's ever taken out the scar tissue. And by the time you get to the late 70s, you are at 217 anyway. And there's no way I can put it in the core, because if I put any more in the core, their brains are really going to explode. It's like there's no room on the laminate, and I have to have something to talk about. Speaking of radiation, and just to integrate the beginning of this conversation with the end of the conversation.
Yes.
We were at Cleveland Clinic, and they had a patient come in at the end of the day, and he had head and neck radiation, what they call woody neck. So the radiation, and he had scar tissue and stenosis in his esophagus. And as I started working on his neck, he starts so you can see the endorphins going up, and he starts crying. And he said, I was a fireman. I was an EMT. And he starts telling us about the things he saw. An accident where the body's here and the head's over there, that kind of thing.
Yeah.
And so I set up a second machine, and we ran 40 and 89 the whole time. It was the only way to get him to stop crying long enough that I could get him to swallow a tablespoon of ice chips.
Right.
Work on his esophagus, because just beginning to work on the radiation and the scar tissue brought up probably all the terror that he felt because he had head and neck cancer, and all the terror that he felt because of his job. And it was the most remarkable. I've done a lot. We're well into double digits with head and neck radiation and radiation. But that one sticks in my mind because here is he's retired, he's in his 50s, and he can't stop crying.
Oh.
It's amazing. All right.
So another question popped in. If someone has gastric cancer and breast cancer, can you run the emotional frequencies neck to feet, or will it affect the cancers in between, or is there a different placement preferred?
Thank God for Arlene Lennox. So we have one paper published in the Journal of Radiation Oncology showing that using frequency modulated microcurrent, so she was using an AccuScope that sweeps from 0 to 1,000 and back again. And she was treating scar tissue just using this sweep of frequencies. And it was an N of 22 or 3. But in that group was a subgroup of, I want to say 3, maybe 4 patients who had active tumor, so a recurrence of cancer, while she was treating scar tissue from a previous neutron therapy exposure from a previous cancer. And the patients that had the active tumor who were simultaneously being treated with neutron therapy again for the recurrence, there was no increase in tumor growth, and they had fewer side effects and responded better to the neutron therapy than patients that didn't get FSM.
And then another quick question while we have 2 minutes. The person has a client who has breast cancer, has had surgery, both breasts, don't know about further treatment. What would I like to know is safe for me to give her an anti-aging treatment?
Piece of cake. Yeah. Problem. If she's had both breasts removed or both lumps removed, and who knows, my challenge is that radiation is oncogenic, so we don't want to get me started on that topic at this late hour. But sure, skin anti-aging and making her feel better, concussion protocol for sure, emotional reaction balance for sure. Vegas, probably not.
Right.
But read The Place in the Core, where it talks about what Harry would do for cancer patients, which was support the adrenals, treat the emotional factors, adrenals, emotional factors, whatever that slide says. Would you, oh, this is back to Suzanne. At the conclusion, assess. No, unless he's got an outbreak, don't touch it. I have an N of
I'll
1.
have you the question for people who can't read the question who are
Oh.
listening. The question was, would you make her run a shingles or herpes, I guess, program at the conclusion of a session as a prophylactic? Your answer was no.
Unless they have an outbreak, leave it alone. Because I had one patient that just was obsessed and continued to run shingles and herpes because he had genital herpes, and he was scared to death of getting an outbreak, so he kept running it. And either it didn't stop the outbreak, or it occurred to me that maybe it caused an outbreak. So if you don't have an outbreak, don't do it.
And sometimes the stress of having it is just enough to so if they're like, for me, if this is my patient that you're talking about, I wouldn't even thinking about running the herpes. If they're so stressed about it, I'd be dealing with concussion, relax and balance. Let's just calm down. It's going to be okay.
It's going to be okay. Yes, exactly.
Yeah. And then last question. So okay to run 40 and 10 through body for the breast cancer patient? Question mark.
Oh, yeah. Oh, yeah, actually, the breast cancer patient that has the spinal stuff, or any breast cancer patient, if she has full body pain, she has stress that contributes to it. And 40 and 10, as far as we know, because it decreases substance P, is only working on the spinal cord. So, yeah, I would think. The only people I don't run 40 and 10 are pregnant. It's like, nope, is sorry, come back in 6 months when you're not pregnant. Bring the baby with you. We'll treat you both for concussion. I'll do 40 and 10 and it'll be fine.
Yeah.
But I won't treat them when they're pregnant. Just won't get it done.
No,
Did 5 o'clock already?
it's 4 o'clock here. I don't know.
Here.
It's overtime there.
Wow, it's 4 o'clock. It's 4 o'clock there because my computer stays set to whatever time it is at home. It's 6 o'clock here, which is why it's stone dark behind me.
It
And
is.
it's the rainy season and it's not pouring rain, which is really fun. And today we had lemurs. No, we had the yellow-faced little monkey in the tree. And we
Oh,
had a family, like a herd of coatis coming down the hill with there were babies with them, so they're reproducing. And then up on the peak of the roof, there's this tile that's got this pointy thing, and then there was a green peak on it, and I thought it was part of the tile until the green thing lifted its head and looked around, and it was an iguana sitting on the roof, sunning itself. It's just, and then last night in the dining room, there was a moth this big, like huge. Kevin got a picture of it with its little eyeball on each wing. And yeah, it's,
amazing.
yeah. And this,
It's
I went
beautiful.
into town today and it's macrame and a stone, and I don't remember the name of the stone, even though she told me 3 times. And there's other little stones, and it's all handmade, and there's this plywood table in the town of Montezuma. You'll find it on the map in southern Nicoya Peninsula. And that's where the local artists put their handmade work out. And, I could have gotten stuck at the first one, but then I kept walking and I got to the one that was closest to the main road. And it was like, and Joseph, who runs Anamaya, said, now be sure and bargain. And it's no, I just no. And
Oh, it's beautiful.
yeah, it
And
is.
the last little comment we had is tonight is a full moon. It's called the beaver moon, apparently. So full
It's
moon,
what?
the
Oh,
beaver.
it is. It's right over there behind the clouds.
Wow.
And
Yay.
oh, it was just, I miss home. I miss you. The concept of being able to do back-to-back core and rehab seminars next October.
Amazing.
There is going to be a limited number just because of the number of sleeping rooms that are available here.
Right.
I suspect that Kevin will get it on the website before anything else we put on the website for next year.
Yeah.
Because it should fill up the fastest.
Yeah.
There will be no non-practitioners allowed in the rehab course. And you're gonna love it.
Yes. Oh, I'm so excited.
Me too.
It's 5 o'clock. It's five after, or sorry, it's after 4. So it's after probably 6 your time. Time is up, is my point.
Next week, I'm gonna be at Echo Villa in Costa Rica at John's house and looking at my house that I bought. We can, oh, I can't do it without you. Kevin's not going to be there.
Then I will tell Kevin right away if I can. I was supposed to have a guest last week that I had bumped. I'm so excited about the guest, so I won't say who it is. But your surprise with Ben made it worthwhile. So just saying. But
then you can have your guest next week. And
yes.
because the concept of doing the podcast without Kevin is like, yeah, not,
No.
no. Yeah. And Kevin has great, he said I was going to be fine. It's like, no. Okay.
All right, everybody. Thank you for coming. Amazing. Enjoy the rest of your time there. And we will see everybody next week. Hopefully, if not the week after, for sure. But
Well, Kim
I'll
will
do my
see you
best.
next week.
I'll be here. Yes.
Yeah,
All
she'll
right.
be there.
Bye, everybody.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.